DKA has some complications, and some of the complications as listed in the slide, these are hyperlipidemia, specifically hypertriglyceridemia, hypocalcemia, hypokalemia, as I mentioned earlier, and hyperchloremia. The most dangerous one of those is actually brain edema, which usually occurs in children. This presents with headache followed by lethargy and decreased arousal at a time when patient should be recovering and feeling better. And neurological deterioration may be rapid, however, with seizures, incontinence, pupillary changes, bradycardia, and respiratory arrest. And this usually occurs with rapid correction of hyperglycemia and hyperosmolality. Another complication of DKA is pulmonary edema, and this occurs usually in patients who have left ventricular failure, ARDS, such as infection in the lung, hypoxemia, or simply overhydration of the patients presenting with DKA. There sometimes occur an idiopathic increase in pulmonary capillary permeability, leading to pulmonary edema, the cause of which exactly is unknown. Hyperchloremia generally occurs in the treatment or at the end of treatment of DKA, and usually occurs in a situation with extremely good urine output, when sodium loss exceeds chloride loss and IV fluid having normal amounts or equal amounts of sodium and chloride. A couple of words about renal failure and DKA. Rarely a patient with renal failure presents with DKA. Here, in this situation, keto acids are retained in body in patients who are anuric or oliguric. And therefore, potassium and fluid losses do not occur in such situations. So patients do not have dehydration. Therefore, you need to be very careful with the fluid balance. And occasionally, you may need hemodialysis for treatment of hyperkalemia. Very important issue in the treatment is monitoring. And here we monitor many parameters in such patients, such as weight on admission and every 12 hours, fluid intake and output every 1 to 2 hours, if necessary, by inserting Foley catheter, blood pressure, pulse, respiratory rate, mental status every hour initially, and then every 8 hours at the end. Laboratory monitoring is very important in this situation. In general, we monitor glucose by finger stick testing every hour initially, and later maybe every 2 hours. Potassium every 2 to 4 hours, and plasma sodium chloride and bicarb and serum ketones every 4 hours. Arterial blood gases, on the other hand, is only necessary at the beginning. Plasma phosphate, magnesium only on admission, and later on you can monitor it every 4 to 6 hours. Urine for ketones every time the patient void, and ECG admission and only repeated when necessary if you suspect there is myocardial ischemia. CNS and renal function are very important and can be done every 12 hours or every day if there is no reason to do it, and chest X-ray only when indicated. This is an example of a data sheet which is extremely important to follow the progress of the patients. Without it, it's very difficult, especially when a change shift in nursing and when the house staff is attending to other patients. Mortality rate has fortunately been declining over the last 20 years or so, and it seems like it is continuing to decline. It hasn't plateaued yet. This is probably due to improvement in medical care and early presentation of patients. There are poor prognostic factors that are obvious at the presentation. These are portend poor prognosis, such as age. So the elderly will have higher morbidity and mortality compared to the young. The lower the pH, the higher mortality. hypotension, and renal impairment, and severe associated disease such as cardiac or pulmonary disease. Most DKA has an identifiable reason, and some DKA cases can be prevented. In fact, in type 1 diabetes, most of them probably can be prevented by patient education. The most common reason, other than omission of insulin, is when a patient becomes ill. So we should educate the patient with what we call the sick day rule. So a patient who is sick should have frequent monitoring of blood sugar at home, and they need to take the same dose of insulin. Most patients believe that just because they are not eating, they do not need insulin, and therefore they stop it. On the contrary, illness and stress from illness increases glucose in the blood more than nutrients. And we generally tell them if blood sugar more than 250 to take an extra 10% of insulin dose. That is 10% of the total daily dose of insulin. So if the total daily dose of insulin is 40 units, they should take an extra 4 units every 4 hours until the blood sugar is less than 250. If there is ketones as well, then they should take 20%. So 20% of 40 units, that's about 8 units extra every 4 hours in addition to their doses. If they are able to drink, then they should take plenty of fluid. If they follow these guidelines and these recommendations, they should be able to stay away from the emergency room. However, if the patient is vomiting, is unable to take fluid, then they have no choice but to come to the emergency room for treatment.